As a pelvic health therapist, you are in a position to help clear blocks that may be impacting your client's fertility. Do you want to learn how? Listen into today's conversation with Dr. Yeni Abraham as she joins me to share incredible wisdom and insight around what we can do to help clients navigate infertility and miscarriage. This conversation will expand your care on multiple levels. Hello, friends. This is Lynn Schulte, and you are listening to the Birth Healing Summit podcast. We are here for meaningful conversations that will transform the way you work with pregnant and postpartum clients. Whether it is a new perspective, tool, or technique, you'll be able to implement it into your practice today. I invite you to sit back, listen with an open mind, and grab the golden nugget today's guest has to offer. Now let's get started. Welcome everybody to this episode. I am super excited to share with you our special guest today. We have Dr. Yeni Abraham with us, and Yeni is a physical therapist. She founded Triggered Physical Therapy and Triggered Academy. She is an educator and a fertility and reproductive health specialist. So welcome to the podcast, Yeni. Thanks for being here.
Thank you so much for having me, Lynn. I'm so excited to be chatting with you again.
Yes, we've had Yeni on in the past. I think it was last year, wasn't it? You were
It was
part of the summit.
it might have been almost 3 years ago now because
What?
I know it's been that long.
Oh my God, where's time going?
I know that because I was very pregnant when we had that. Yep. So about
Okay.
3 years ago now.
Wow, I would not have thought that, everybody. Holy cow, this is amazing. Okay, so Yeni and I are going to be talking about fertility insights because that is your specialty, Yeni. And I think as practitioners working in the pregnancy postpartum space, this is a huge topic that we need to be aware of. And I know you have a whole certification on fertility and becoming a specialist or understanding that more. So let's dive in today on some of these insights. What do we as practitioners need to understand about fertility when we're working with our clients?
Yeah. Well, I first want to just say this because I think I always kind of, whenever I speak to, especially rehab folks who are, they hear I do fertility, and the number one question they always get is, should we be there? Like, are we allowed to work in this population? And I know your face is telling
Yeah.
me,
What?
you're like, yeah.
Yeah.
Yes. And I always say, well, absolutely. If we're managing neuromuscular communication, we're managing what the vagus nerve is doing in its interaction. What makes you think that that's not going to impact the endocrine function, the reproductive function? So why wouldn't be there? And especially if you're in pelvic health, you're already in the geography. So you should care
Right.
about organs, how they're functioning, and hormone health. And without a doubt, hormone health, understanding hormones is the future. It's the future of where medicine is going. We see so much conversation now about menopause, and now we're learning that it's not just about menopause, but really how do we support women from menstruation to menopause and beyond. And that's kind of where my heart is. And the patient population I've always worked with is menstruation to menopause, right? There's all these life cycles and changes that are happening. And so even at a basic elementary level as clinicians, we should have some understanding of what to do when these folks walk in our door, right? And understand right away what direction this is going.
Well, I think what makes this topic so intriguing and maybe um, what's the right word? The right adjective to this,
Yeah,
a little complex
yeah,
is
yeah.
the different aspects of it. I think that sometimes practitioners think, oh, well, that's a hormonal thing. I don't really have any
Oh, yeah,
impact on that, or I can't influence that in any way. But I think when we are talking about fertility, we really need to know that there's way more aspects that we
absolutely.
do have influence on beyond the hormones.
Yeah,
And
absolutely.
really, our physical care can influence the hormones, can't they?
Absolutely. They absolutely can. And I mean, I think the best way in the gateway in even having this conversations in a way that a lot of clinicians understand is talking about the conditions that typically will link and present themselves, and disrupt MSK pain, right? And, even if we're talking in pelvic health, we know endometriosis, and we know endometriosis as a condition itself can create so much substantial havoc to the body, chronic inflammation, systemic inflammation, especially if we've got widespread lesions, in the abdominal cavity, but we don't often recognize that these conditions can oftentimes disrupt reproductive cycles and reproductive options for people. And so the way that I kind of like try to talk to people about on a basic level is, endo at its core, it's an inflammatory issue that creates adhesions that then disrupts neural upregulation, right? And so these three principles then can interfere with the lumbar spine, the hips, the pelvis, and overall, the lumbopelvic region that can impact even outside of menstruation, right? And so, even I've seen, and I'm sure you've seen this in your work, you have folks that is this myofascial pain? Is this
What
a
pain is
sciatic
this?
pain? What is this? Is
Yeah.
this fibromyalgia? Whole time it's endo.
Yeah.
Whole time it's endo, right? And so, and realizing that these adhesions that form do cause restrictions that then can look like musculoskeletal issues, right? And
Yeah.
so I've mentored and spoken to sports medicine folks. I remember I did a talk at a large sports medicine clinic here in the area, and I remember like there were a couple of light bulbs that went off when I talked about endo specifically. And you see all these, folks that work with these high performance athletes who felt like they've been kind of at the end of their rope with certain people because they're not seeing much progress. And it's like, did you forget about the organs? Did you forget about the systems, right?
Yeah.
Because it's like, well, I mobilized the sacrum and I decompressed it and nothing changed, or I've
Oh,
loaded the spine.
but nobody's thinking about the connection between the uterus and that
Absolutely.
sacrum and the pelvis. And
Yeah.
Yenny, I have to say, the more I work with the uterosacral ligament,
Oh yeah, absolutely.
the more I'm just like blown away. Like I really feel like that is one of the biggest kingpins in the
Oh
whole
yeah.
pelvic space.
100%. Yeah,
Yeah.
Lynn is my kind of person. I mean, if you guys know, like we're gonna geek out real quick, so just hang in there with us. But that's my favorite uterine ligament as well.
Me
And just
too.
because one, typically when we have radical hysterectomies or even just honestly basic hysterectomy, that's the ligament that suffers, right? And oftentimes you don't know how much you want it there until it's gone.
Yes.
Right.
Yeah.
But often, Lynn, especially when we have our stage 3 and above endometriosis, most of those lesions are found on the uterosacral ligament. So if someone has debilitating posterior diffuse pain, especially when they're going to do any thrusting activities, flexion activities, I see this a lot, especially in my volleyball players, folks that have done any like high impact jumping and dynamic movements who have an underlying diagnosis of endo. It'll always present with like this posterior, and almost time it refers to the tailbone, and it's tricky. So if you don't know to think organ, you can sit there and keep thinking it's an alignment problem or it's a muscle tension problem when that's far from it.
Well, and I think we need to uh,
Yeah.
remember our anatomy, everyone, and
Uh-huh.
that the uterosacral ligament most likely attaches into the sacrotuberous
Absolutely.
coccygeus complex. The
Absolutely.
majority of people are attaching in there, and
Yeah.
that can be the indicator that could be creating some of this pain. And the other thing that just blows me away about the uterosacral ligament is the inferior hypogastric plexus that
Oh my
runs through the
gosh.
middle of it.
Absolutely, right? And then when you've got those between S2, S4 attachments, right? You don't often realize, and by the way, and thank you for reminding us about anatomy because I keep an anatomy textbook close by when I'm treating typically because I've got to always remind myself. And one thing that a lot of people don't appreciate too are just the complexity of referral pain patterns. And what I see clinicians often do is they're symptom chasing, right? They're
Yes.
forgetting that especially in the pelvic cavity, those referral pain patterns can be very confusing,
Yep.
very complex. So this is why you leave nothing to question and you don't always rely on the musculoskeletal presentations to tell you everything, right? I am obsessed with visceral work for this reason because I have healed more and supported patients further along in their healing by treating viscera more than I've done with MSK.
Well, and that's just it, because when you do address the viscera, the MSK just lets go.
It does.
And I one of my tenets that I teach is I don't treat pain. I
Mm.
treat immobility,
Oh my gosh. Oh my gosh. Yep. 100%. Once
right?
you get to that point where you are not looking to get rid of pain, you will actually get rid of pain.
Right. Say that one more time, Yenny, because that's so
When
important.
you get to a point as a clinician where you are not looking to get rid of pain, you will actually get rid of pain. I mean,
Right?
it seems so silly, right?
Yeah,
But it's
yeah.
real, right? And I think
Well,
go ahead.
well, I was going to say I was teaching over in London last week, and I was working on someone, and as I was doing the release work, they're like, "Oh, I feel it here," and I
Mhm.
actually said to my students, "I'm like, I don't really care."
Yeah, I love it.
Which
Yes,
sounds, like everybody looked
yeah,
at me like, "What?" And I go, "I know that sounds harsh."
yes.
Yet when I'm releasing something and I'm on the structure that doesn't move, if it creates pain elsewhere, that's actually a beautiful thing.
Yes,
I don't
yes.
want to go chase that pain. I don't want to go where that pain is. I want to stay where I'm at and treat the immobility. So I'm sorry, that was such a
No, I love that you said that just because I think even when we're talking about postpartum care, postnatal care, or we're dealing with gynecological dysfunctions, whether that's PCOS, adhesions, you name it, the temptation is I've got to go chase that. I've got to go investigate why that is happening, right?
yeah.
You will kill yourself as a clinician if you keep doing that because
Well, yeah, go ahead.
I know because I was gonna say a lot of what is happening when we're releasing and we're doing the visceral work is you've got layers of neurological suppression, emotional and energy that's coming up,
Yep.
right? And
Yep.
that can go and so it's like the gal I always think about this patient of mine that I saw years ago who, we'd been working on her. She had really poor case of PCOS. I'm talking about like 100-day menstruation,
Oh,
really hormones out of whack, a lot of abdominal adipose tissue, difficulty managing her diet, stressful living, low libido. So the whole complex, right? And, she's Hispanic, which most people don't realize that a lot of Hispanic women can be pre-diabetic, predisposing them to having PCOS. And so she just checks off all the boxes, right? And we've thrown everything but the kitchen sink into her, into suggesting her to make some of these changes. And it seemed like there was a lot of persistence in some of the symptoms that she was having. Like her cycles were getting better, but she was still experiencing lethargy. She was still experiencing constipation and fatigue, right? And so I'm going in one day and I said, I'm going to take a step back from the viscera and I'm just going to work on the peritoneum. Like I'm just going to work on the peritoneum, see if I can find any sticky areas in the peritoneum that are just restrictive and see what happens. Wouldn't you know it that I'm talking like super pubic area, right? And I'm working almost urachus. Lynn, she starts getting this heavy pain in her stomach
oh
to the
wow.
point where she's wanting to almost throw up, right? So she's getting nauseous. All right, so everything is shifting there. All right, so she's getting all this nausea. We've got to stop, give her a break. We go back and same thing happens. And I asked her, I said, okay, and this is the difference between symptom chasing versus clinical investigation. All right.
Yes.
Symptom chasing would be, oh, well, let me get on top of her, the peritoneal part of her stomach and see if I can release that. Don't do that. You're gonna waste your time. You're gonna be stressed.
Yep. 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 Yep.
I just asked her, okay, have you ever felt anything like that before in your life?
Mm-hmm.
Right.
Yeah.
And if so, when was that? Oh my God, yes. The same thing used to happen to me when I would force myself to throw up when I was a teenager. Oh, okay. All right. So we've got an eating disorder to history that never came up.
Right.
That
Right.
that now is okay. So what's happening is you've got this reproductive desire, and then you've got this old you from when you were 14, 16 years old that you had body dysmorphia, and then that's coming ahead, right? And so all right, and then we've got to step back and talk about your weight and how that's actually mentally a burden to you. And then we go that direction. That is what we call good clinical investigation. Now, I know if you're listening to this and you are an ortho girl, okay, through and through, I just freaked you out.
Right. Yeah.
Because you're like, how do we get there, right? But what happened was there's something and Lynn, I think, oh, I love the way you talk about this, but I think we share this in that there's a way that you have to have a clinical instinct, right? When there are things that come up in sessions where you don't go and, go down a rabbit hole chasing things and get distracted, but you respect the nudge and that gut feeling and indication enough to say, this is worth at least talking through. Like there's something that's happened here that we can't deny. And then, we are able to unlock. And I think that's what happened that day. And so we double down and we talk about her weight and we talk about, dieting and get some more nutritional support. She's losing more weight. Her cycles are getting better. hormonal balance is being restored. Some of her MSK pain that she was having that was diffused is going away. Bingo, we're unlocking something.
Right. And so, Yenny, I think where some other people would go is that's counseling. We shouldn't be
Uh-huh.
doing counseling.
Like, yeah. And I don't know. What do you think about that before I answer, Lynn?
Well, the way I approach that is we're using the body
Yeah,
as our litmus test or the guiding tool. So,
absolutely.
for you, you were on her Urachus and
Yeah.
that triggered the response.
Yes,
And
absolutely.
so it's through the tissues then that I would just get curious as to what I was feeling in those tissues. And when we listen to the response in the tissues as we are asking questions and they answer those questions, the response lands in the tissue or not.
100%.
So, I see it as more we are guides dialoguing with our clients and we're using the tissue as the response indicator because, and I think it's a deeper, it's a more effective way
Mm,
of um, doing it. I mean, yes, you could call it counseling,
sure.
and I put those in quotes, but it's counseling through the body, which the
Absolutely.
body cannot lie.
Will not lie. It will tell you, it'll tell your business if you let it, right?
Right,
It
if you let
it'll
it.
and I think even non-pelvic clinicians who, end up seeing folks who have hormonal issues or who have fertility problems and, oftentimes feel like they're constantly dealing with persistent pain that doesn't typically fit in these orthopedic
Yeah.
patterns.
Yeah.
What I would suggest to you is that just maintain high clinical suspicion at all times. And I think
But
that's what's going to help, right?
yeah,
Is
I
being
would call it
suspicious.
curiosity.
There you go.
I
There
would
you go. Yeah.
curiosity versus suspicion,
Yeah,
which is the
suspicion is
same
kind of
thing. Right. But suspicion makes
yeah.
it sound bad,
Yeah.
right?
And
Like,
of course this is one of those times where I'm like, don't love that we just speak English, right? Because it's almost restrictive to call it suspicion. But
yeah.
curiosity is a great example of just being curious and allowing that investigative nudge to take you to those places, but being aware that that is part of the beauty of what we do when we get to touch, right? And I always remember I had a great mentor when I was in PT school who Dr. John Winslow, I always kind of talk about him every so often, and he would always say, that the issues are in the tissues, right? This is the guy that stayed on bone, that did cavitations and did all this like, exercise work with us, but he would still say, when all else fails, the issues are in the tissues. And sometimes you've got to go back to those elementary voices and just remind yourself that I know tissues. Why am I ignoring tissues, right?
Right. Right. And I think it's when, like in your example, when there is a response in the
Yeah.
body
Yeah.
from your work in the tissues. And for those of you doing intravaginal work,
Oh,
it
yeah.
happens all
All
the
the time.
time. I truly feel that those therapists who are just doing the level ones and twos and just learning the basics of intravaginal work, I
Yeah.
feel it's a disservice to those therapists to not know how to handle or address when emotional stuff comes up.
Oh my gosh. And I mean, that was something I was going to mention, right? When we're really talking about what are those insights that clinician, and it's really going back to that trauma-informed care. Like, how do you understand how to handle that tone? And I don't mean this in a negative way when folks say, well, that's just counseling, but I almost think that in a way that's a bit of a cop out as a clinician, right? There's parts of you that may feel uncomfortable with going in that direction. And I beg to say that this is where it comes to your development as a clinician. Why is that the case? Why do you feel uncomfortable with that?
Bingo.
Right?
Bingo. Yeah.
Investigate that. You go see the therapist, you go see the counselor, you go do the journaling and meditate and think, why am I uncomfortable with going in that direction? And don't explain it away that it's not within my scope of practice because, honey, it is, right? It is within our scope to do this work. But I think you've got it. And I think doing trauma informed care, working in these tougher, more complex populations like infertility forces you to acquiesce to a higher level as a clinician. You hold yourself to a higher standard. you hold yourself to a better form of integrity and ethical care, but it also makes you do the deep work as an individual. And I think that when you're doing that constantly, you're going to serve your patients from the overflow of all the good things that you're doing for yourself, right? And how you're doing the soul care.
Yes. Oh, I love that. Yenny, we so speak the same language, just a
Yeah.
little bit differently, right? Like and I love that we both come at it in different
Yeah,
angles, right?
yeah,
But we're saying the same darn thing. And that
absolutely.
I truly believe we cannot take someone to where we have not gone ourselves.
So good. Oh my God, brilliant. Yeah. That's just the way to put it, right?
Yeah,
And I think that's and for someone, and so I'll say here just on a personal note is I'm somebody that I really, really treasure being authentic to myself in all aspects of life. And and I think you cannot be who you're not, right? Especially as a clinician. And so if you're, asking yourself, what can I do? Why should I be doing this? I think you should do yourself the due diligence of doing the work so you can be authentic. Because what's really happening here is you almost feel like you've got to cosplay being a different type of clinician than you really are. And I think patients are safer when you're authentic, right? Patients are safer when you're again serving from the overflow versus feeling like you're at a deficit and you're, low key Googling their symptoms before they walk in and hoping for the best.
right? Yeah. There,
So yeah,
I
yeah.
I love that. I love that. We need to and I love being authentic. Our clients can pick up on that or not.
Absolutely. Right away, right
And
away.
yeah, and so you're if you want better clinical outcomes with your
Mhm.
clients, it starts by being authentic with yourself
Absolutely.
and showing up in that way that allows that client to be able to go where they need to go.
100%, 100%. And I think, at a clinical level, especially when you're dealing with a fertility population, you're going to run into trauma. The prevalence of trauma is just higher among these individuals, right? And so we know that research shows that even women undergoing infertility treatment typically have a higher history of, childhood trauma, sexual abuse, adverse reproductive experiences, whether that's miscarriage or they've had, several procedures or abdominal surgeries that have created challenges. And so they're already coming with some like I call it like a baseline hum of some trauma. And it could be micro traumas, like these little instances that have happened throughout their life. And so if you are unaware of how that's manifesting, right, and what that potentially is doing to inform the way they're showing up, it can catch you off guard. It can be a little bit frightening to see what that's going to potentially do the way that you're treating them.
Yenny, how do you sense the trauma
Mm.
in the body?
That's a deep question.
Can
So
you?
it's like how do you sense the trauma in the body? Now, there's two ways I can answer that. There's the energy that comes into the room with the individual, the way that they carry themselves, the body language, the way they explain their condition, what they decide to talk about, what they decide to focus on. I'm a church girl, and in the church we'd call it reading the room, right? You would just get a scan of the room and what that person brings in. You can pretty much tell where that person is at in their care, their receptiveness to healing, the level of autonomy they probably previously had or the lack thereof in their care. And so, how much of this is I'm coming here to get fixed versus I'm coming here, I don't want to be here. I don't trust you. Let's see what this is going to be.
Yeah.
Right.
Yeah.
So that takes one a lot of repetitions in this work. I'll be honest. Like when baby Dr. Yeni was a hot mess. Like, I mean, I was like, I barely knew what I was going to have for lunch, talk less of what was going to go happen, in the in the patient's room. And I'll be very candid here. But I think when you lean into caring and recognizing that the assessment begins even before the first conversation, the assessment is as much verbal as it is nonverbal. You learn to appreciate how patients are showing up, right? And I can even get into the granular details because we're going to talk about trauma informed care, especially we've got to talk about like the patients, how they show up. Did they shower? Did they, what's their physical appearance? I'm not talking about judgments, but I'm talking about, you could pick up on if somebody's depressed or they're operating in a place of anxiety based off of just how they're showing up at their appointments, right? And I think that those nonverbal things, are they eager to take off their clothes without you asking versus waiting for you to step out and then doing it, right? Those are some things that you can start to be able to take note of as you are asking the questions. And then there's that second piece when it comes to touch, right? How we are sensing restrictions, how we're sensing energy blockages and energy flows. And I will say that this is something you cannot explain as much as you must experience as a clinician, and allow yourself the permission that it takes to be able to allow someone's body to give you information about where they're at, right? It is not something that you can impose, it is not something that you can provocate and force. It is something that you have to be open to receiving. And so, whether those are somatic holding patterns, if you want to explain it, their way they're presenting central sensitization, or just downright, holding on to energy, hardness, toughness, firmness, softness, the
Yeah.
letting go. Those are all things that I could feel at the shoulder, the back, as well as feel in the abdomen.
Yeah.
Yeah.
Okay. So you said two words that are four words, really: energy flow and energy blockages.
Mm-hmm.
How do you perceive, and this is kind of going off topic here, guys,
Oh,
because I'm
you're good.
my curiosity here. How do you perceive those four words are
Mhm.
accepted or not accepted in the physical therapy realm, in the physical therapy world?
This is such an interesting conversation, Lynn, because you know me. I live in the, so I'll say this, I'm going to give you some context. I live in the intersection of evidence-based and the unexplainable. That's just where I'm at. And I've accepted it,
Love
I've
it.
embraced it, that true holistic medicine is being okay with doing the unexplainable that gets you incredible results, right? And almost miraculous results, right?
Yes. Yes.
And just again, going through enough evidence where we can at least, make some level of sense, but I'm not married to the sense if it's not going to get me there, right?
Right.
And I think for a lot of clinicians, and I honestly will blame the era of evidence-based that a lot of us came out of, is the way we were nurtured and we were taught in our education that
Yeah.
if it's not in the evidence, it's not honestly permissible. I think that is really informing a lot of clinicians, whether or not they realize it or not. And so let's take it back to the way medicine was practiced centuries ago,
Yeah.
right? Let's
Yep.
talk about that, right?
Like
And we can talk about, so and my background is I'm Nigerian, so I'm like first and a half gen because my dad went to college here. So I'm first
that.
and a half. But
All right. Yeah.
and I think about the fact that, let me give an example of my postpartum rituals in my culture, right?
Mhm.
Somebody comes, my aunt comes, stays with us for a certain amount of time. I'm eating certain things. There's certain teas that she's making me, drink every day, for God's sakes. I mean, my bladder's full, but all kinds of things are happening, right? There's these rituals that come with being postpartum that is natural, the way you eat, the way you're supposed to dress, how you're supposed to hold on, what your posture, all of that. Those things honestly have no evidence tied to them, but they work. And we have been doing them for centuries. Our Asian counterparts have them. Our Spanish or Native American counterparts have them, Mexican, Mayan. There's all forms of iterations of inexplainable, non evidence based ritual practices that do wonders in the body. And so, why then do we, when we get a degree, forget that any of that exists and then only want to practice medicine in a way that makes scientific sense?
Yeah.
I beg to differ. Didn't
Yeah.
make sense,
Yeah.
right?
Yeah.
Then
I agree. I agree. I love that. Thank you. Thank
no
you for that.
problem.
Yep. Yeah, I wish that we were more open
Yeah.
as a profession. Sorry, talking to PTs here.
Yeah.
I wish we were more open to newer ideas.
Yeah, absolutely. And I think, and you know what it is? I have hope. I didn't a couple years ago, but now I do. Um, I'll be 100% honest with you. I really did not have a lot of hope a couple years ago. But what's changed is folks like us that are teaching and that that have platforms like Lynn, your podcast is so, it's a revolution in itself because you're willing to have conversations that are off the beaten path, right? And I think if we're giving more spaces, if, the folks that came from before us, who I think did the best they could with what they knew, are okay with a new generation of educators and audacious clinicians to just come through and stir the pot, I think we're going to be better for it, for
I
sure.
Oh, I love, love, love hearing that. I love, love hearing that. So, okay, what else do we need to know about trauma-informed care that you want us to be aware of?
Well, I definitely think that those are some of the main things that I'd mention, just that realizing that this population is going to have a higher prevalence of trauma. There might also be some what I call neurophysiological hypervigilance, right? They're just super aware of certain things and holding patterns. And so the main implications for most therapists is being aware that you've got to have permission-based practice, letting patients, be able to communicate what they feel comfortable doing. Would it be okay if I, right? Or how do you feel if we went this? Or being able to even just check with them verbally, where are you at today? I think that's so powerful.
Yeah, and I hope that everybody listening in has that ability to sense in for the pause,
Uh-huh.
in for
Uh-huh.
the like, like, oh, I'm not 100% sure on that. Like the pause, and when you ask that question and you don't get that immediate sure, no problem,
Yes,
but that
absolutely.
pause is that hesitation from our
Absolutely.
clients that
Absolutely.
we need to be aware of and more sensitive to.
Yeah, and just be more respectful, recognizing those somatic responses. Like if they're guarding, if they're holding their breath, if they're suddenly getting tearful, or maybe they withdrew after you asked a certain question or did something. I think that that could often reflect some unresolved trauma that that person has. And don't forget about therapeutic alliance and how it's your job to create a level of emotional safety that's going to directly impact that patient's ability to relax and engage in their care. And so in this population, especially who may have dealt with some levels of grief, especially if they've had miscarriages or shame, we don't talk a ton about the cultural implications of going through infertility, how folks are feeling ostracized from their communities, from their villages because they're not conceiving and they're not starting their families, or even just the perception that my body is betraying me, right? And so those are some things that are constantly informing the way that they're showing up. And so being able to create those therapeutic alliances, naming it, sometimes giving them the language for what they're feeling but may not be able to communicate, I think can be very powerful.
Yeah, that's
Yeah.
awesome. I love
Yeah.
that. Yep, love it.
So definitely, and so I got to talk about red flags because I just came.
Yes,
Yes.
yes. I was going there next, so I'm glad you mentioned it.
Well, and I'm happy that I get a chance to talk about this because I think, when even earlier when you were mentioning, well, this is counseling, I'm like, those are the things that you don't really have to consider red flags and issues. The real red flags are there are some scenarios as a clinician that are going to come up that are genuinely out of your scope or can be harmful for you to take on if as a clinician solo, right?
Yeah.
And so I'm big on interdisciplinary care, especially in the fertility population. A lot of the clinicians that take the pelvic rehab fertility specialist program with us learn that you've got to have a group of people that you have in your community that help you see your patients. You've got to have a couple of great reproductive endocrinologists you're talking to, great nutritionists who understand infertility, who understand what endo and PCOS and fibroids can do to the body. I really love speaking to, getting a lot of therapists involved who specialize in this population. I think the reproductive population and their needs are very different, and I don't think a general therapist is appropriate. And I beg to say, I also involve a lot of sex therapists in this conversation as well, just because a lot of people don't know this, but you will see a lot of sexual dysfunction problems come up in the fertility population. And so, whether that's rooted in trauma or identity issues, it's worth having a team of support there.
Yeah.
And so, when these are some like my top things, red flags, like when it's time to change course and get another therapist involved, is I would say this is where when we have persistent pelvic pain, let's not forget, right? The pain is unchanging, it's non responsive to visceral care, MSK care, all of the interventions that you're doing are nothing is changing, and of course we're not seeing any menstrual regularity changes. It just remains persistent. We've got to investigate that, right? What's going on there?
Yeah.
Lynn, there was years ago where we caught a tumor, right? We caught a tumor in the pelvis that everyone had missed, right? Because I was the only clinician they ever saw that actually saw them enough frequently to be able to track that this is inappropriate pain, right?
Yeah.
And so I think that was a really helpful way of just being able to advocate for the patient, like, okay, let's get some imaging, and then we were able to find that there was a tumor, and thankfully they were able to excise it and get it out in time
Good.
before it metastasized. So
Great. Wow.
yeah,
Yeah.
so.
Yeah.
Another red flag I absolutely would encourage us to consider is, and especially for my folks who are non-pelvic, is the unchanging dyspareunia. Unchanging. And for folks who don't know, dyspareunia is when we're having any painful intercourse, right? And so unchanging dyspareunia that doesn't seem to budge at all, can be very indicative of underlying dysfunction that might require a specialist. And so these are for, especially for my general PTs or OTs that don't see a ton of pelvic. Maybe you're someone that just sees a lot of prenatal, postpartum, and then, suddenly your patient is complaining of painful intercourse that's unchanging. Get a specialist involved and let's investigate. Of course, another one is menstrual irregularities or sudden changes with amenorrhea, like they were having their cycle and then suddenly stopped having their cycle. There's a phenomenon called hypothalamic amenorrhea that we see a lot in active population, and it's essentially that the hypothalamus can sometimes disrupt the process of menstruation. And so they're not menstruating, they're not ovulating, and those things we need for pregnancy. Yeah.
When you say active there, Yeni, are you talking someone who's physically exercising and athlete active, or how do you define active there?
Oh, that's good. So I'll say it in this way. Every individual has a level of metabolic resiliency, and a lot of that has to do with genetics and lifestyle decisions, right? But there are some individuals that they typically test their limits in their training.
Yeah.
And whether you want to chuck it to what cortisol is doing in the ability to regulate it, I don't think that's the explanation alone. I think we have individuals that do test themselves. And I remember I worked at a sports medicine clinic and I saw a lot of, Ironman, ultra marathoners, folks that they were willing to do whatever it took for however many months to train. And Lynn, I'm sure you've come across those in your career.
Yeah, yeah.
And
I do live in Boulder.
oh yeah, okay. So yeah. 'Cause what? Let me tell
Well,
you
it's the
what's doing
triathlete training area,
it is.
state.
Yes. And then there's the university up there that does a lot of training. Yes. And the honest truth is, extreme training will compromise you metabolically. And when you have a compromised metabolism, it will impact your reproduction. It's like, and I'm not, and no matter what you believe, it's almost as if like nature knew, God knew that, the moment like your body's under a level of persistent stress, you don't need to be reproducing,
Right.
right? At
Yeah.
all.
Yeah.
And that's usually what suffers, right? I see this also if we see the thyroid have dysfunction, especially whenever we see folks that have thyroid issues that are not well managed. Seeing a goiter, which can be a growth in the neck area that can sometimes indicate, Graves' disease. Those are some of those things that, unfortunately, if we do not have an endocrinologist in the loop of care that is providing even just low dose medication to help to modify that, there is nothing that you're going to do as a therapist that will help to improve that on its own.
Right.
Mhm.
I just had a conversation with a good friend of mine who is a physician, and
Mhm.
she was sharing with me how she has her own direct primary care practice.
Yeah.
And I think this is important for all of us that are doing, we probably spend the most amount of time with our clients.
Yeah.
And that what she highlighted to me as I was with her was that the fact that a lot of practices are now going to NPs and PAs.
Oh my gosh, yes.
And what she was sharing with me is that these NPs they could be in cardiology one day and they could be in reproductive health the next day and they have no advanced training.
Wow, absolutely.
And so we need to be more inquiring of our clients as to
Mhm.
who did you see? Because if
Abs-
they're not seeing the doctors and they're seeing their NP,
Yeah,
not getting that same quality of care.
yeah, absolutely.
And so
Absolutely.
I think that's even more of a reason, Yenny, that we need to have this education and we need to have the information to be able to best guide our clients to get that, to know about the thyroid, to know about,
Yes.
these things. Because unfortunately, medical care these days is
Oh my
not
gosh.
what it used to be.
It's not. I mean, it used to be that when you saw your physician, they knew so much about everything. And I think the conversation we're not having in healthcare is we're not accepting that the game has changed and the nature in which education is done has changed, and
Yes.
how much dare I say it, for the last 15 or 20 years we have left a lot of clinicians to decide how they want to stay educated and how they want to continue to improve in practice, and there's no longer those level of regulations or that standard that is kept. And so even for folks listening right now who have wondered, well, how am I going to do this with fertility? I'm supposed to see this population. Fertility concerns may not walk through your door announcing themselves, right? As therapists, you just have to know enough to recognize when chronic hip pain isn't really chronic hip pain or pelvic girdle dysfunction, right? When that restricted abdominal tissue is potentially giving us a broader reproductive, health story than we're probably letting on, right? And so I think that the world is changing. If you didn't know it, I'm gonna, let this podcast be a confirmation. Healthcare has changed. Lynn, you're spot on. There's been a decline in the amount of medical students that are going to medicine now. Medicine itself has changed. It's become a game of specialists. There's not a lot of good generalists anymore.
Yeah.
And so the job of a generalist is now in the hands of PAs and NPs,
Yep.
and their work is hard. Insurance has not made it easy to be profitable as an NP and a PA by being a specialist. And so you have to be really good at moving around and seeing multiple types of patients throughout the tenure of your career. And that unfortunately means you will miss a lot, right? And that over reliance on technology versus good training and good skill set is also lacking. And so this is where us as, and I don't always love this term, but it is what it is, us as allied professionals
Mhm.
get to really be the allied professionals that the medical world is needing, because they're going to need us more than ever before.
Absolutely. So Yeni, tell us more about your program and what we can gain from taking it and learning more about fertility to help support our clients.
Yes, and so I'll just say this, that now that you've heard a lot of discussions, you might be thinking, okay, all right, what are we going to do now, with this
Yeah.
information? And
Yeah.
I'll say, when we started the pelvic rehab fertility specialist program in 2022, the goal, because at that time I'd been doing like master classes here and there and teaching small courses, but the goal was to really give folks who are in the pelvic health world, and so it's not just PTs and OTs, but we've also have NPs, PAs,
Oh,
and DOs,
good.
and MDs take these courses, right? Is to give a comprehensive curriculum that says, okay, from end to end, even though this is at the core of fertility, from menstruation to menopause, how do I ethically treat this population? How do I see them and come alongside them to make changes in their hormone health, or their endocrine health rather, their nutrition? How do I help them to navigate and leverage nutrition? So there's a lot of holistic principles we're going to go over, but we're going to talk science as well. We're going to make sense of the evidence as well as leaning in. So there's a good integrative balance. I think a lot of the clinicians who take the coursework enjoy. But this is, a lot of it is online, it's hybrid. You do get to come and decide to take a 1 day lab intensive, and then there's a case study you submit afterwards, which solidifies your real world experience, and then you get certified. And this is the real deal. It's held with integrity. We've got a peer advisory board that we make sure that all of our clinicians are well taken care of. We've also got a trademark now that legally protects the name, and so you get to use that name post nominally, but it's giving us an industry standard that I think that our field desperately needed, to be able to really make sense of how do we still talk science but talk holistic medicine.
Love it. Love, love, love it. Yes. Awesome. Wow. Thank you so much, Annie, for
Thank you for having me.
all the wonderful work that you do and what you're putting out into the world. I absolutely love it. So thank you. I hope those listening in will be intrigued to check it out more. And we will put your website and your certification program links in the show notes, everybody. So please check those out. And we hope that a lot of people are signing up for you yet. Um,
Yes, yes.
tell us more. When is the like you do them in cohorts, right? And when's the next one start?
So we've got our next cohort starting on September 9th, and the cohorts usually run about 10 to 12 weeks. They're mostly, we'll have live classes every week, and we've got study halls. It's super fun, y'all. You get to take them with colleagues all over the world. We've got folks that have taken it out of the US already. It is just a really great learning opportunity. So I hope you join us and you check us out at triggeredacademy.com. I think you're going to have a great time.
Awesome. All right. Well, thank you so much, Annie, for your time. And thank you, everybody, for listening in. We are definitely The soul
Endurance.
sisters on the therapy train, aren't we? As far
Yes,
as
we are.
bringing that all together, it's so
Absolutely.
important. So
Absolutely. Thank you
thank
so much,
you.
Lynn. Appreciate
You're
you always.
welcome. All right. Thanks everybody for listening in. We'll see you on the next episode. Here is to smoother births, faster recoveries, and better fertility for all of our clients. Take care, everybody. Bye bye. Today's podcast was brought to you by the Institute for Birth Healing. To discover more, visit instituteforbirthhealing.com. To claim $50 off of any online course, use coupon code PODCAST50 at checkout. Till next time, I'm Lynn Schulte, founder of the Institute for Birth Healing.